Hello, my name is Alexis, and today I'll be discussing the topic for my final paper, the opioid crisis in white America, for our class Masters of Public Health 603 Applied Behavioral Science. First, we must discuss what is the issue. The issue is that whites are being highly affected from opioids. More whites than minorities are misusing and dying of overdoses because of the drug. The opioid crisis has been around since the 1990s and began to peak again in 2010s. The main issue was that many primary care doctors are overprescribing or improperly prescribing opioids to many white patients. It is important to note that many opioid users are first introduced to the drug by first being prescribed to them. First, there begins the opportunities for addictions, and then misuse, and then overdose. Patients are no longer prescribed opioids, there is still full dependency and addiction to it, which then leads to more illegal drugs and more dangerous drugs as well, such as fentanyl and heroin. The underlying issues are income. Studies have proved that many low-income Americans are more likely to be addicted and die of an opioid overdose than high-income communities. Income can affect the kind of healthcare one has access to, and the area in which you live alone can affect the type of education received. Access to drugs, the people you surround yourself also. Healthcare access is an important issue to this topic. During one of my research topics, I found out that many Medicaid patients are being prescribed and are addicted to opioids compared to non-Medicaid participants. We will also be discussing this topic in further detail in the next slide, as I see it is more important compared to the other disparities as well. The third is pre-diagnosed condition. If someone has a pre-diagnosed condition such as chronic pain, this can lead them to use opioids more than someone who does not suffer from this. In addition, I have also had to add biological trauma such as PTSD or stress that can encourage the use of substance to help curb the pain. There are some genes as well that can cause predominant addiction behavior such as family history or abuse or substance addiction. These factors can also be connected or underlie one another as well. As stated earlier, access to healthcare is one of the main issues. Studies show that white Americans have access to healthcare more than compared to any other minority group. Even with laws such as the Affordable Care Act, it is still not accessible for, just let's say an example, a non-English speaking minority who is not a citizen. Eligibility requirements require citizenship, which also limit the opportunity for a minority to enroll. However, even those minorities who do receive access to healthcare, there still proves to be a discrimination against race. Minorities are more than likely to undermine or not be taken serious on the same health conditions compared to the white counterparts. Doctors are more than likely to prescribe medications to a white patient than of a minority. There's also the stereotype that has been proven that some primary care physicians will not prescribe medications to their Black patients with the fear of it being sold or misused. It is because of this that minorities find themselves at the main issue of opioids. Many primary care physicians are also not well educated on how to properly prescribe drugs, and many of them overprescribe or do not properly teach their patients about the drug or the dangers of it. The underlying issues are what have caused many white Americans to be the main target of the opioid crisis. This is uncommon, as we usually see minorities being the main ones affected during healthcare disparities. So what has been done? During my time in this course, I have come to the conclusion there have been many approaches and interventions based on many theories that have been intervened through this community. In my first approach, I will be discussing the theory of fear and emotional processing. During one of our discussions, we discussed the fear tactic approach. For example, I used this photographer named Montgomery who would go around the state of Washington with law enforcement and photograph incidents of opioid overdoses. This was done to implement fear into an individual to prevent them from changing behaviors. However, this can be flawed at times. An image can be powerful because not only does it show the results one may go through and how it could affect those around them, and it can be a cue to action in one's environment in order to change one's behavior. However, fear is not always effective in changing risk behaviors. Referring to the health belief model, I believe that this image can express perceived severity, but not perceived sexability. Images can definitely serve as a cue to action, but can result in fear control or defective avoidance, and may not be personal enough that can be easily ignored. If fear is implied, it is important that it results in perceived susceptibility by stating that one's modifying factors are. It also depends on what stage and how deeply that person is engaging in that perceived risk behavior. The second approach I looked at was based off the information behavioral model. This was created by Fisher, and there are 3 constructs to this model. In this study, they went over information that can be described by the relevant knowledge of the behavior. In this case, it was information on how to use opioid antagonist drugs. The second construct is motivation. Motivation combines one's individuals and attitude about the behavior in order to engage their motivation to engage in the behavior. Based off these 2 constructs, the third was behavioral skills. This construct can be explained in one's skills and capacity engaging on the behavior on their own. This study again looked at naloxone to provide high-risk users to see if they would engage in medications to stop overdoses. Naloxone is a prescription that is intended for high-risk users, an opioid antagonist. Study shows that it reverses the depression, serotonin caused by opioids, and it is not addictive. It is a great supplemental addiction to cravings and prevent overdoses. It reduces the number. The purpose was to reduce the number of hospital visits and overdoses in the state of Washington. In the end, they found that their studies were null. The study was done on January 31st to April 3rd, 2015. I felt that the study should have been remains longer and have been involved in more follow-ups of specific individuals. Their outcomes are being determined based on the number of hospital visits and even excluded the homeless population. I feel that this community can have been benefited by a step-to-step process. I feel that it is effective to imply only education alone. Even though I took a lot of this information based on my research, I made sure to add more steps and concepts into my intervention. I chose the prevention program in which educated individuals on injecting opiates and how to safely use the drugs, determine overdoses, and use antagonist drugs on themselves and others during an overdose. The purpose was to distinguish participants into 3 groups based on their familiarity with the opioid overdose prevention program they provided. They used the theory of diffusion of innovation theory. Innovation can be a new product that is available and aid the process of adoption. Communication, second key is communication, which helps spread awareness of communicating with others about the innovation. The third key is time, when time is important to determine a realistic framework in which an innovation will be completed. The last key is social system. The social system is the population that is targeted. In this case, the targets in this study were people who are injecting opioid drugs. It was proven that individuals who were exposed to the intervention through organizational staff was more than likely to adapt to the program compared to those who were exposed through their peers. I used this study because I based a lot of other findings during my intervention. Here I based off my logic model due to my studies. For my intervention goal, my goal was to reduce opioid overdoses in America with users who misuse the drug currently. I did a harm reduction in model because I feel that it is hard to get high-risk opioid users to just stop using the drug completely. It would be safer to implement a harm reduction program. For my activities, I would provide one-on-one counseling or therapy for users. I would set goals to help them reach every week and month. And I would start educating them on the harm reduction and what to do if experiencing an overdose. So have them practice using naloxone and teach them about the benefits of using naloxone. The components I have included are have individuals taper their opioid consumption with the help of coaches, caseworkers. So I do not again expect them to completely stop using opioids, just to lessen and taper their medication or prescription or any illegal drugs that they may be using. I will begin substituting the opioid with antagonist drugs such as naloxone to satisfy withdrawals and prevent from overdoses. The outcomes, I hope to complete the intervention after 6 months and continue them in follow-up for 6 months after. After follow-up, is their intention that opioid overdoses rates will drop. Of course, implementation and translation are an important part of the intervention process. For my implementation, I hope to incorporate any cultural adaptations without posing any threat to the fidelity of the program. Modifications will be made to the core elements, such as income, gender, education, and family history of abuse and support of the individuals. These coaches and therapy and personal goals will help set these implementation changes. Translation is the dissemination process of the intentional spreading of the information of the intervention to promote the program and spread awareness. I will make sure to use a city that is predominantly white and has severe opioid overdose cases. I would like for the coaches to go out and be a part of the outreaching team to implement trust from the beginning, and so that participants can be more encouraged to complete the intervention. Thank you for your time during this presentation. I appreciate everything that I learned throughout this course and will hope to carry it with me throughout my next courses. Here is also a list of all the references I have used throughout this presentation. Again, thank you for your time.